staying tuned. Let's delve straight into it. In this segment, let's reflect on the critical global efforts to combat tuberculosis as TB, a disease that continues to impact millions worldwide, as the world just marked the World TB Day on March 24. This year's theme calls for renewed action and solidarity to accelerate progress in TB prevention, diagnosis, and treatment. Through community engagement and field work, significant strides have been made in raising awareness, providing education, and delivering vital health services to underserved populations. We will look at how position in the fight against TB, from access to testing and healthcare, treatment, stigmatization, and all what there is, as well as the role of community leaders and health workers in breaking down these barriers, fostering trust and encouraging individuals to seek early diagnosis and treatment. We'll also look at the place of poverty in tuberculosis. To have this conversation with us, we have Program Manager, Akwa Ibom State TB Leprosy Burule Ulcer State Program, Dr. Basi Agban. He joins us live. Dr. Agban, you're welcome to Niger Delta Today.
Thank you very much. Thank you.
Good afternoon, sir. Thank you for joining us.
Good afternoon.
Let me start from one of the very popular questions that usually come to mind when the issue of TB arises. Is TB a poor man's sickness?
Well, majorly it is, but not totally a poor man's sickness. Why it's poor man is because it's linked to poverty, because poverty comes with poor nutrition, comes with poor housing, poor education, and a whole lot of other sequelae of poverty, but not lack of money in your pockets. And its spread doesn't look at poverty. It spreads to all people in the social strata. It goes to everybody. So yes, we have it commonly amongst the poor, but it really reaches the rich.
Okay, so let's expand it now for the benefit of those who may not really know what tuberculosis is all about. Could you lay it out on the table? What is tuberculosis, and why is it so important that we tackle this?
Okay, tuberculosis is a bacterial infection, and it's spread from person to person. When an infected person coughs, when they cough, they bring out droplets. You know, I mean, if you have to breathe in front of a mirror, you could actually see a mist, a fog in front of a mirror. So you can imagine, for every time you have breath coming out from your lungs, you're going to have some droplets. Now, tuberculosis itself is a bacteria that is found in those droplets. So it takes an uninfected person to walk into those droplets and inhale them to get tuberculosis. So that's why it's quite important. That's where the poverty ring doesn't come in, because I mean, as long as you are breathing and you walk into where you are within 3 hours where someone has been, you are 3 hours staying in a room where someone is coughing, there's a high probability you could get the infection. And unfortunately, tuberculosis is a killer disease. And in fact, it was the highest killer before we had COVID come on board. And it's still known as the most infectious disease known to mankind.
Okay, let's come now to the activities your unit put together for this World 2025 World TB Day. What were the activities you put together?
Okay, yes, we had basically we had to go out for outreaches. Because we know that the most important part of our mandate is actually to find what we call the missing cases. Okay. The missing cases are those cases that are known statistically to have the disease but have not been brought to treatment. Okay. And as long as we don't bring those people to treatment, the chances are that they're still spreading it there in the community. Okay. So the idea, we go looking for them. Formerly, we used to wait, patients come to the facility, we treat them and they go, but we realize that most times some of the reservoirs of disease are still there in the community. So basically we went out this year. Every local government, as we speak right now, there's still kind of outreach activities. The flag was done at Ibesibo Secondary Commercial School, just along the road to Nungodo Junction, where we met with so many children were screened that day, and well, we're still looking forward to seeing the test results. We also had another one at Lutheran School, still in Ibesibo. Okay. It still ran concurrently to local governments and several other local governments. I speak to every local government. I had 1 or 2 outreaches moving forward to commemorate this day. But it's not just a World TB Day thing. It's now our norm in the state program to make sure that we go out looking for these cases every other day. We're out there in the communities. We have what we call the portable digital X-ray machine, where we don't have people who have to move all en masse to a chest X-ray center. Rather, we'll take the chest X-ray down to their facility. So we have about 7 of them in the community, and we're expecting another 5 that will be based in some facilities well spread out geographically in the state, so that everybody has access to it. And it's free.
Okay.
Even the outreaches are free, the testing is free, the medications are free. So we're actually advising people, especially in Akwa Ibom State, to please make mention. And then even throughout the country, outreaches are happening all over the country to commemorate this TB day, which it works with a week of outreach activities.
Well, when we talk about how free access is to persons who want to test for TB, treat TB, some people may still find it unbelievable. How do they locate these places where they can get tested, where they can get treated conveniently? Is that enough awareness that has been created to show that people can easily have this information at their fingertips?
Okay, yes, we have been doing our best, and we're still doing our best, and we still the opportunity today to still send a message across. We have over 700 treatment centers across the state. 700. So that gives us an average of over 20 treatment centers in each local government. So I can tell you that comfortably, you'll be surprised that the next health post or health center to you actually is a treatment center. Currently, we are close to saturation of all our health facilities right now. Even a lot of the private facilities, formerly it used to be public, we've even gone as far as entering some private facilities, we're offering TB treatment there. And it's absolutely free. You don't need to pay for anything. When you go and say, I want to screen for TB, you get access to those treatments. And our testing platforms have greatly increased, from what we had last year to this year. Currently, we have several testing platforms. We have 14 for the gene expert testing. We have 11 for the TrueNat testing, and we have 4 for the TB-LAMP testing. Those are WHO recommended testing platforms of which we have made available spread across the state so that you don't need to go beyond 2 local governments to have access to those testing facilities. And now the PDX machine, which is an hour with the X-ray is what we used to test to, we now have community volunteers that move them with the radiographers, moving to the hard to reach areas of the state to make sure that people are tested for TB. And when they are tested positive, they will get their treatment at least at the closest health center to them, so they don't need to undergo catastrophic spending in assessing treatment.
Okay, now the 2025 World TB Day, the theme is Yes, We Can End TB. Now, how would you describe the compliance level in this community engagement? How is the compliance level, and is it their level of compliance? Is it something that actually gives you the notion that yes, we can end TB?
Yes. The compliance has quite been good. I mean, if you even look at the way when we went into the secondary school, the best school, called the best school, can see the way everybody came out, everybody followed, and you can see the children answer 1 or 2 questions, correctly about what TB disease is, what are the signs and symptoms, and it was quite exciting to know that. I mean, awareness has been quite created, even though a whole lot more needs to be done, but you can tell because, last year we had a program where we actually had to put tuberculosis into the school health clubs, program. We had booklets, the school health clubs have their booklet, but we now had a TB, we had the conventional diseases there, measles, HIV, but we now have TB included in it. And so that when the children are doing their health club, they'll be able to talk about TB. And by the time they talk about it, of course, that's awareness. There are situational success stories where children actually went home and told their parents that have been coughing that, look, Mommy, there's treatment for this and it's free. Let's go test. And they now found out they were free. And the whole household is treated and everybody is okay. So a lot has been done as regards community awareness. You see us even come on the media. It's also for that, for people to hear. We're also on the radio because not everyone has access to the visual media like this. We equally do our best to make sure that everybody gets this TB message, that TB is curable, TB treatment testing is free, TB treatment is free, and TB treatment is quite close to you.
All right. Now, talking about, before we even go to how you get your funding and some of those very details that has to do with monies, would you say that some of the symptoms, when a person coughs, for instance, is that enough to say you want to go for a TB screening, or is there a kind of cough, a kind of symptom that you experience that you would say, okay, this is enough proof that I need to go for this screening? At what point do you decide that I need to go for a screening?
Okay, yes. If you haven't coughed for 2 weeks or more, the 2 weeks or more is significant in the sense that, it tries to distinguish other forms of cough from the TB cough. The coughs that are caused by irritation, you could have a meal now, you have some irritation in your airway, and you could have some cough, or the food went through the wrong pathway, so to speak, and you cough. That one will resolve over time. A few hours, it's gone. Then if it's the one for the normal environmental, can I say, influences, you know, maybe your allergies or so, that one goes and comes up. But the one caused by TB, you would have gone to a health center, taking medication, the conventional antibiotics and what are they, and meanwhile it doesn't just go. Because the TB medications are quite specific for tuberculosis. They are not a conventional, most of them are not a conventional antibiotics. And once you get that particular treatment, you're cured.
Well, when we talk about how serious this is a global threat, tuberculosis, I mean, the word has always been there and talked about how important it is that we keep drumming this message into the ears of everyone that is available to hear. How much of a threat is tuberculosis currently?
As long as we have missing cases out there, it's still a threat, because it means those people are spreading it to 10 to 15 people every year. So that's the threat tuberculosis has, and it touches everybody. And what I could say is less a threat is the fact that, unlike other diseases we had, the Ebola, the COVID, you know, we didn't know where it came from, we didn't know what medications to use. TB testing is known, the treatment is known, the treatment is quite effective, the treatment is not that debilitating like some other illnesses, and it's curable, as in you could get treated for TB and it all goes. So that reduces the threat. So the angle, we need to bridge the gap between the people's knowledge, the social behavioral change for the people, and actually access to this. So while the government has been doing their best to increase access to treatment, that's why, like I mentioned, all those the testing platforms are well spread across the state. You know, we're doing all of that. It will be of no use if the people don't come out to access this treatment. It will be of no use.
But during the outreaches you had, there were schools and communities visited.
Yeah.
Your observation during this field work, where does it leave us in this fight against TB?
In the fight against TB, we really need to look at what the people think. We need to change the mindset of the people, and equally healthcare workers. You know, healthcare workers out there, we need to look at quackery. We need to see how we can do something about quackery, because even when we still look for how to train and retrain healthcare professionals, we still find out that there's still a whole lot of issues that we still need to sort out amongst them. You know, we still need to give them regular training. You know, we still need to get so not to talk of quackery out there. So people need to be aware of these symptoms and treat them accordingly.
Okay. Do we have high-risk population in Akwa Ibom State? Because I know there is what is called high-risk population. Do we have that in Akwa Ibom State?
Yes,
and how is the unit handling that?
Yes, we do regular screening of those high-risk populations. One of them is like our correctional centers. That's the high-risk population, and the reason is quite obvious. You know, they are usually not well nourished, and you know, and the poor living conditions. You know, they don't have too much ventilation, and they're usually crowded. You know, so we're expecting a whole lot of them to actually come down with this disease. You know, and also we look at places like the IDP camps, you know, and so refugee camps, any form of camping. You know, we'll have crowd of people where there's overcrowding. We can equally have that. We have the orphanage homes. You know, most of those children below the ages of 5 who have low immunity are exposed to it. Then also looking at other people that suffer from some other diseases like HIV, people that suffer HIV and diabetes mellitus. Those two illnesses will predispose someone to get the TB disease, because both illnesses reduce immunity. Yeah. But the good thing is that if you have HIV and diabetes and you take your medication regularly, good viral load suppression for the HIV and good blood sugar levels for diabetes mellitus, trust me, immunity gets boosted and the patient feels better.
Well, how often do you come in contact with people who are co-infected with tuberculosis, HIV, and diabetes, and how do you manage it?
Okay, well, the program has not really gone deeply into pulling diabetes mellitus cases, patients, you know, as vulnerable. But we've been working quite closely with the HIV, and I can tell you that last year, 60% of our patients actually were co-infected, meaning that the total number of patients we saw, you know, 16% of them were actually people that had HIV and TB, you know, yes. So while we even treat for TB, we also do our best to see how we can synergize and make sure that the people that have HIV continue the medications, you know. For those that have not even knew on the first instance, there's a protocol we take to treat the TB and HIV. For those that are already on HIV medications and had the TB problem, there's also protocols. So we all follow the protocols to the letter and make sure that at the end of the day, the patient benefits.
Okay.
Now, what is this drug-resistant TB strain? Is there something like that? And what are those impacts? How does it affect the work that you do?
Wow, drug-resistant TB is it's not very good news when it comes to TB disease, because drug resistance means the strain the person has, actually the individual has either the individual or the person that infected the individual had TB disease, got treated with TB medications, but did not complete the duration to suppress it. So for that reason, the bacteria itself immediately gets resistance.
Emboldened.
Yes. So for patients that take the treatment, the common duration of treatment for the drug susceptible TB, which is the opposite of drug resistant TB, is for 6 months. So for people that start the treatment and because they feel better after 2 weeks or 3 weeks, they just abandon the medications, they have the tendencies of them coming down with tuberculosis, drug-resistant tuberculosis. But for those that treat for the 6 months, there's a very little chance they could come down with that. Now, for those that are unfortunate to come in contact with those that stop their medications before the completion, cannot get that strain. It's a big problem because the medications used for that is quite a little bit more sensitive. I will use the word sensitive compared to the other medication. The other ones, like I said earlier on, quite friendly, not much issues. Even pregnant women can take it, But for the drug susceptible, for drug-resistant TB, the caution really needs to be taken. The drugs are not so comfortable like the others. Not that bad.
Is it also for an extended period?
It's for the same 6 months.
For the same 6 months.
Yes,
okay.
for the same 6 months. But I mean, the tendencies, we even have to do a whole lot of testing in between to be sure that all your indices, biological indices are okay while you're taking the medication to the completion at 6 months. Okay. So it's not really fun to have drug-resistant tuberculosis. So for people listening and already started treatment for TB, please make sure you complete your 6 months so that you can be TB-free.
Okay, you talked about the drugs for TB treatment being safe for pregnant women, meaning a pregnant woman can actually take those medications and still feel safe throughout her pregnancy.
Yes.
So is it possible, for instance, a woman that is infected with tuberculosis to transmit this disease to the unborn child?
Okay, no, not really. It doesn't transfer through the placenta, the bacteria, but the challenge is that by the time the child is born, the woman cannot transmit to the child. Okay. Because if you look at a breastfeeding mother, if you look at the position of breastfeeding, the child is actually looking up to the mother. Sure. The nose is looking up, it's like a funnel. And the mother is talking and speaking and
singing lullabies.
Singing lullabies, go to sleep. The baby going to sleep and is most probably inhaling. The child is most probably inhaling the bacteria. So actually, there's a high chance, and the child between 0 to 5 years of life has no immunity of his own. Okay. The child is using the immunity of the mother, borrowed immunity for the first couple of months. It starts to build disease. At about 5, we can say the child starts building its own immunity. That's why I see some of us have children, and I mean, on their 5th birthday, you're so happy because like, at least I'll stop running to the chemist and the hospital every time for these kids. So that's the basic reason. So the process of the child having TB, and the worst part is that diagnosis of TB in very little children can be so difficult, even for healthcare experts.
Why so?
Yes, because they don't come with the typical symptoms for TB.
Coughing?
Yes, they might not come with coughing. Okay. They might just come with they're not growing as much as they should grow. Wow. They could just a child should weigh between 8 to 12 kilograms at 1 year. But you could see a child weighing like 6 kilograms at 1 year. That could be childhood TB. Okay. And even moving ahead, So what we call failure to thrive. When a child is not growing the way it should grow, one of the possible things could be TB. The child might not be coughing because cough is a reflex. Yeah. Reflex from immunity. So if the child's immunity is not really boosted, the child might not even be coughing actively like you expect the child to.
All right. Well, another very crucial aspect would be how trustworthy is the methodology that has been put in place globally for the tackling of TB. Would you say that you're satisfied with the approach that has been deployed so far? And what is the funding like? How do you get support for the work that you do? I mean, you say you have over 700 centers spread across Akwa Ibom State alone. Yeah. How then do you coordinate? Where do you get all the money to do all these things?
Okay. First of all, let me start from the funding. We have funding both from the government and also from outside partners, international partners. Although we had a little glitch recently where the USAID, issue came in and affected part of our funding. I think for now, some of that funding has been returned, not fully. When you look at it from the government part, I can just looking at it. For example, I'm a staff of the government, and my basic duties the fight against TB in the state. And the team lead to manage the fight of TB in the state. And that makes you, and that's government effort, because I mean, government pays my salary while I do the job, you know. So I think we, at times, most time, we tend to look down on government efforts when it comes to financing this thing. But we have partners that do help us out, and I think, and they come up with a whole lot of innovations in between. Example, like you're talking about the global fight, we have a lot of innovations that's coming. Like the medications we use now is not what we used to use before. You know, for the drugs resistant tuberculosis, the drugs we used before could cause deafness, could cause what is it called? Even blindness. You know, there are a whole lot of things they could cause. But currently, those medications have been pulled out. We're using new medications right now that are a little more friendlier to the individuals. Also, even the treatment, we used to have the drug that used to cause a lot of problems called streptomycin for the normal TB. But I mean, it's no longer in the system. A whole lot of innovations. We now have the mobile X-ray machines, where a whole lot of technologies coming to the treatment of disease that is making it better. Well, mobile X-ray machines, unlike before, we had to pack everybody to like University of Uyo Teaching Hospital for X-rays. You know what I mean? Logistics and other issues that could come on board. But fortunately, we don't have those kind of issues again, because we're not taking the X-rays to them in the community. So if you have to do X-rays for 200 children, instead of pulling them, you can imagine how many bus we need to do to pull that out. Now we're going to them in that community with our machine, and we can do up to 500 children, depending on the strength of the radiographer and all of that. Yes.
All right. So talking about working with children and community during your community engagement, what are those challenges you face as health workers? Because you are the foremost of this fight against TB. What are those challenges that you face?
One of the challenges is that when you go to a community, they believe everything is political, and they just feel that, I mean, where's the money? Where's the money at the boot of the vehicle? Bring it, let's share. And I mean, they come out and say, we don't even have food to eat. What kind of drugs? What drugs do you want to give to us? These drugs, are we experimental guinea pigs? You know, those are issues we have had. But I think that issue usually comes up when we don't have a good community engagement at community entry level. Because by the time we go to a community, we're supposed to go sit with the gatekeepers, the village head, you know, the chiefs, council of chiefs, the youth leader, do a social mob, you know, social mobilization, whereby everybody's agog and knows that, oh, this is going to happen, this is going to happen, you know, and you now pull out your machines. And in between, we do our best to bring some other adjunct medicines, you know, things like blood builders and the rest, you know, so that at least some people that you feel actually might be really down, but you tested them and feel that they don't have TB. I mean, you could just, as social help, you could just help her. Like, look at some of our outreaches we did that day. We actually had some adjunct medication. And for the schools, what they say, like biscuits, you know, and stuff, at least for the children to feel happy. You know, for that time they're standing in line for their test. I mean, they could just snack on something. You know, those are little things we do. But, you know, people still have that sense of entitlement to health for the government, which I don't blame them, because actually it's their right, you know, but they don't really understand how the healthcare financing works, and we don't blame them for that either. But we in the sector will do our best to make sure that they get the very best that they can get.
All right, Dr. Alpan, there's this area that is also very crucial, and that has to do with vaccination. I know that growing up, we talk about polio vaccination, talk about measles vaccination. Is there something like that, a vaccination for TB that can sort of, maybe not 100% credible or effective, but is there an arrangement for a vaccine that is supposed to be administered to maybe babies when they are born, so as they grow, they don't get down with tuberculosis?
Yes, all right. There's a vaccine that is currently on ground, and it's been, in fact, not currently on ground, it's been on ground for many years now. It's called the BCG, the Bacillus calmette-guerin vaccine. Is given to a child on the first day of birth. It's expected to be given to the child on day 0, as in the day the child is born. As soon as the child puts the breast to mouth, the child should be surrendering his left arm for the injection, you know, so for the vaccine. And normally we're expected to do that within a week of birth. Why? Because after a week, it's suspected that, I mean, during child naming, someone comes, carries the baby, this beautiful baby, and is not coughing. You don't know the people within the naming ceremony. The child now can be exposed to the TB bacteria by then, you know. So it's advised is done as early as possible. So the idea is that if you don't even have access to the vaccine on that day of birth, maybe it happened on a weekend or a public holiday, make sure the next working day you're at the health center to get the vaccine. And the vaccine is totally free. And on the whole, there's actually a vaccine for tuberculosis that's still in the making, and I'm not in a place to tell how far it has gone, but we might know one of them days, the same way malaria vaccine came up, we'll have the TB vaccine come up.
Well, I'd like you to shed some light on the current situation of TB in the Niger Delta region. At least you would have some statistics as regards whether we are making any progress, or we are slacking, or there's more work to be done. How collaborative has the main actors and stakeholders been when it comes to the engagement with interface with different governments of the Niger Delta region? Has it been a smooth sail, or are there still work that needs to be done?
Yes, like I said, as long as we still have TB as a problem, as in a public health problem, then the journey, the fight is not done. We still need to put in more efforts. I'll say for the region, Niger Delta region, we normally meet every 3 months, and our zona, we call it a zona review meeting. We sit back and review our data in the zone, state by state, to see how far we've gone. We critique, we talk other things, and make recommendations. We come out with communiques that are sent to the National TB program on 1 or 2 issues. And usually those communique points are usually resolved, and at the end of the day, they come out like new policies, on 1 or 2 things to do. Because while we're working, we believe that there's no perfect system, that we could have 1 or 2 glitches. So mostly because the national program makes the policies, at the state level, we do the implementation of these policies. So we now tell them how it is, and we now sit down together and now do our best to make sure that everything is synergizes to make sure it works better. So in the zone has been doing so well, talk about Cross River, Akwa Ibom, Rivers, Bayelsa, Delta, Edo State. We've actually been doing our best to find the missing cases. The gaps are still there. Last year we suffered a setback as a country, in the world and as a country, not to talk of the zone, because there's a drug stockout. There's an international drug stockout of TB medicines where the company based in China, had 1 or 2 issues with the production. So for that reason, there was a big shutdown, and we had a little lacuna in our normal supply chain. But that has been resolved. As we speak right now, in Akwa Ibom State, we don't have any backlog of old patients. All patients that were in the waiting line have been treated, and we're looking out for more. That's why we started going all out for the outreaches, so that we can find as many of those missing cases as possible, and place them on treatment. Because that's the basic way to eliminate TB in our time.
Okay, now I like the momentum that the unit is using, especially for this World TB Day 2025. The momentum is massive and it's commendable. But how then does the unit plan to sustain this momentum all year round to make sure that the work that needs to be done, or that has been done during this period of the commemoration, is continued?
Okay, yes. We actually, to us as a state, I'll speak for Akwa Ibom State, outreach is not a new thing. We always have outreaches. In fact, the World TB Day, yes. Okay. So the World TB Day is not really a new thing, it's just that we're doing a little bit more centrally, let me use that word centrally, but we always do outreaches, every local government have outreaches that it's being carried out every other week, every other month, and those outreaches, we have community workers. They do either door to door. Okay. When at times they don't do outreaches proper, like say marketplaces, they now do door to door. They go house to house, asking questions, screening people. Either by the time you finish screening, either you're placing them on treatment, or you're placing them on what we call the TPT, TB preventive therapy. The idea is to clear the reservoir of the TB disease in our community, and once we do that, we can be sure that we'll be quite close to controlling this disease. So the momentum is still there. It's part of our daily, part of our task. And currently in the States, we had made sure that we have started what we call the 3rd weekly, because our children are quite important. I mentioned how difficult it is to find children with the disease. I know children congregate more than adults. You see them in schools, you see them in play areas, churches, and all of that. Churches, they're the ones that shout the biggest hallelujah when you go to church. So if you go to children's church, you'll find that out. So for that reason, we have them in mind, and we've done make sure that for all outreaches that are done in every local government, the 3rd week is specialized for children. Okay. Let's go looking for the children. So the X-ray machines will always be there. We'll be going to schools, going to orphanage homes, everywhere we know children congregate, we'll see them. And except during the holidays, that might be a little difficult, which we're just going into. But we'll go there, get these children screened, and place them on treatment. I believe that by the time we do that, and the children, and in the long run, we equally sensitize the children in this manner, so that they go home and tell their parents what they've heard. And you know, children, if they want something from you, they can know how to
They
bug
can
you.
really nag you
So
to get it.
it's one of the low-hanging fruits we're trying to use to see how we can eliminate TB in our state.
All right, Dr. Akpan, just one for the road. We know as to whatever we do, we recognize the terrain we're operating from. We're in Africa. And everything usually, especially when it has to do with health issues, there will always be misconceptions, stigmatization, and all whatnot. Are we still dealing with the issue of stigmatization? And when you want to peg it at the level of awareness that has been created, would you say that we've made incredible progress as regards people understanding what TB is all about and the need not to stigmatize but tackle the disease or virus head on? Okay, yes, I would say we've done quite well when it comes to health promotion, when it comes to TB, in regards stigmatization, and I can say that for sure because I know what the scenery looked like when I came on board, a few years ago, and I can tell you that the feeling on the field is no longer the way it was then, because I know people are now understanding TB, and in fact, I see the major gap in our health education status as regards TB is actually access to treatment. Access to treatment, but not that people are afraid of, oh, you have TB and all of that. No, that you are a witch or a wizard or you are suffering from the gods because you didn't drink water from the stream or you didn't do this or do that. No, it's no longer at that level, So we are just basically looking at how we can strengthen that social behavioral change by letting people understand that TB treatment center is close to you and it's free. And once we can do that, of course, we can never really get 100% social behavioral change, but I mean, we're looking at possibly having up to 70%, even though we're not really measuring it, research-wise, but I'm sure that we're getting quite close to a very reasonable number because I don't really see people feeling bad as someone has TB. Rather, they're like, just get treated and let's move on, And the only challenge I know we used to have is, oh, these drugs are going to finish all my blood and all of that, but it's not totally true. In fact, it's not true, not even totally, it's not true. It's not going to finish your blood. Then the one for children shouldn't be the one you shouldn't fear about because the children drugs come in very lovely formulation. It comes in dispersible, tablets. So you put it in water, it's very sweet to drink, very, very sweet. Trust me, the children will be asking I'm sure even adults would want to try that one.
I'm telling you, yes. So it's quite sweet and all of that, it feels like some form of, creamy stuff, candy kind of stuff. So
something that you look forward to.
That's it. So the kids will always tell the mom, give me the drug, and let parents not be afraid. Those drugs will not shorten the blood of your child, rather to make your child healthier and stronger.
Indeed. Thank you very much, Program Manager, Akwa State TB, Leprosy, Buruli, Ulcer State Program, Dr. Basi Akpan, for making our time to speak with us on these issues. Thank you very much for coming on the program.
Thank you very much.
Thank you for joining us, sir.
Thank you.
Well, there you have it. That's the size of Niger Delta today. Many thanks for following us up until this moment. But remember that you can always track our activities, all of which you can find on our website, adbntv.com. My name is Xavier Robert, wishing you a terrific weekend.
And I am Awe Ruswogene Ebo. Bye for now.